I'm Hamza Hashmi. I'm a physician at Memorial Sloan Kettering. Um, in my practice, I see patients with multiple myeloma, smoldering myeloma, and MGUS. And today I will be talking about the basics of myeloma, the diagnosis, presentation, the risk factors. I'll also briefly talk about the principles of myeloma treatment, as we call them, the do's and don'ts of myeloma, and then briefly touch upon the role of bone marrow transplant, where why do I believe that stem cell transplant is the Tom Brady of myeloma treatments. Um, we'll chat about relapsed myeloma, and then we'll also talk about some of the basics of CAR T and bispecific antibody treatment for myeloma. My philosophy is that when I give these presentations, I actually tailor them to my audience. I don't like to drown my audience in numbers, stats, figures, and data, but in fact give them highlights, summaries, and take home messages. I share some pearls of wisdom from the grandma's old recipe book. And then finally, I'm a myeloma doctor in 2024. So you will see a lot of memes in my presentation and hence the identification as a millennial. So let's start off with a real life patient of mine's study. A 65-year-old female, a school teacher who actually came in to see me for a consultation for relapsed myeloma. The patient has had many different lines of therapy, at least 7 that we could count, including a bone marrow transplant previously. The patient presented with significant anemia, very short of breath, very fatigued, very tired, that you see with anemia oftentimes. We performed a bone marrow biopsy that showed about 90% plasma cells in the bone marrow. She was having a lot of bone pain, so we did a whole body PET-CT scan that essentially showed the skeleton to be riddled with bone lesions. Um, I discussed the option of CAR T cell therapy with this patient, and I asked her what her motivation was for pursuing that treatment. And she told me that she has her very first grandchild on the way in about 6 months' time. And she wants to make it to that day so she can hold the grandchild in her arms. What happens to this patient, whether she goes to CAR T or not, what happens during CAR T, and whether she is able to live up to that day, we'll find out by the end of this presentation. I'll keep it there as a suspense. Moving on to myeloma. Multiple myeloma is a group of plasma cell disorders. All plasma cells are essentially white blood cells that are grown up, mature, differentiated. They perform the essential function of making antibodies that fight infections. Um, there are 3 different kinds of blood disorders in this plasma cell disorder spectrum, including MGUS, smoldering myeloma, and symptomatic myeloma. The big differences between the 3 is that in MGUS, we usually have less than 10% cancer cells in the bone marrow. They make small amount of protein, but it doesn't cause any major damage to the body. In patients who have smoldering myeloma, they tend to have more than 10% cancer cells in the bone marrow. They make protein a bit more than what we do in MGUS, but that does not cause any damage to the body organs again. And what happens in multiple myeloma is that anytime we have more than 10% cancer cells in the bone marrow that makes protein that causes damage to important organs in the body, we define it as myeloma. Important thing to remember is that all patients with myeloma start off with a precursor condition known as MGUS. Typically, it's 5 to 10 years prior to that diagnosis of myeloma. My patients ask me all the time, did I acquire it last night or last week or month? The answer is no, it's been there for a while in the body as an MGUS. Let's walk through the corridors of history to give you some historical perspective on this blood cancer. The very first time in history that we stumbled upon a case of myeloma was back in 1844, when a young female presented with debilitating bone pain, eventually succumbed to the bone pain, and upon autopsy was found to have a giant red tumor in her pelvis. The tumor essentially melted under the autopsy knife, and that autopsy report actually is a part of historical archives now. 100 years later, we did the very first randomized clinical trial for multiple myeloma. That was again in 1950s, where we gave patients with myeloma either the chemical urethane or placebo in the form of Coca-Cola. And for the very first and perhaps the very last time in history, Coca-Cola made people live longer. Uh, simply because the chemical urethane was too toxic for the myeloma patient. And we learned the lesson not to do any harm to our patients from that trial. Fast forward 2002, we have two myeloma drugs. 2024, we have 25 drugs in 50 different combinations. As Dr. Rajiv alluded to it earlier, they have been exponential leaps and exponential advancements in myeloma. And that is what has actually provided us with all these therapies in modern times and age. Sometimes I talk to my myeloma patients and I tell them that the treatment options, when I look at the guidelines, remind me of the Cheesecake Factory menu. There are too many options to pick from. Few facts about myeloma is the 10% of all blood cancers, second most common blood cancer in US. About 35,000 people get diagnosed with myeloma every year, and 7,000 folks actually do a bone marrow transplant, and nearly 13,000 people die with this cancer every year. In 2005, average survival for myeloma patients was around 2 years. In 2015, survival improved to 5 years. In 2025, we are expecting the average survival for a myeloma patient to be 15 years and beyond.